and I'm here to talk to you today about tackling anterior knee pain. Thank you, Ashutosh, for touching on the topic a little bit before. So anterior knee pain can affect up to 50% of patients who have ACLR. It can delay rehab timelines, it can impair function, and of course it can slow down the return to sport. So as physiotherapists, it's really important for us to understand risk factors, the causes, and also the evidence-based management for how we proceed with these patients. Why does anterior knee pain occur after surgery? Well, generally it's because of a combination of factors, okay? The most obvious factor is the surgery, okay? We can look at the graft choice. Of course, the patellar tendon autograft has the highest risk of anterior knee pain because it has a direct influence. Basically, you're grafting from the patellar tendon. There's going to be some scar tissue and some inflammation in that area, and the patellar tendon is in the anterior knee area. So that's the most common graft where you get anterior knee pain. Also with the quadriceps tendon graft, there's an increasing use of that at the moment, and there does seem to be a less occurrence of anterior knee pain than with the patellar tendon graft, but we're still getting a lot of data from that. And of course the other common autograft that happens is a hamstring tendon autograft. It has a much lower risk of anterior knee pain, but it has a little bit of an indirect influence on how the anterior knee functions because the hamstring tendon causes some hamstring weakness and can alter the knee mechanics. Also, in regards to the surgery, we can look at the tunnel replacement. If it's a poorly positioned graft tunnels, as one of the doctors mentioned earlier, it can alter the knee biomechanics and cause patellofemoral joint stress. And an anteriorly placed tibial tunnel can cause excessive knee translation, which then overloads onto the patellar tendon, which is at the front of the knee. I think one of the other things is quadriceps inhibition post-surgery. Of course, the arthrogenic muscle inhibition reduces the quadriceps activation post-op, and this leads to weakness and the altered patellar tracking, which increases your anterior pain risk. I think the other thing which the doctors are also stressing on at the moment is respect the meniscus repair. So if there is a meniscus repair that has also happened with or without the ACLR, then we need to be mindful of that as well, because of course that can influence the way the knee is extending and therefore can overload the mechanics of the anterior knee area. Apart from the obvious surgical factors, there are biomechanical factors. So patellofemoral joint stress primarily is the main thing, which is caused by quads inhibition and increased pressure on the patellofemoral joint. And poor functional loading. So when you're sitting to standing, you're squatting, using the stairs, all of those things can anticipate the load on the anterior knee. Also altered lower limb mechanics. So compensatory movements due to pain or weakness, such as excessive hip reliance, but also ankle dysfunction can increase the knee overload. Increased knee valgus and poor single leg control can lead to patellar maltracking. Other reasons why anterior knee pain occurs after surgery is primarily because of quadriceps weakness. We've spoken a lot about that earlier in the presentations. It's a primary contributor to anterior knee pain because weak quads leads to instability in the knee. And, patients come back to us and they say, oh, my knee feels really unstable even though I've had the surgery. And you've got, my graft hasn't taken, or there's something wrong with the graft. And I think that's where it's important to make sure that you're talking to the patients and saying, actually, your quadricep muscle is not yet strong enough, and that's really influencing how you feel about the stability of your knee. And of course, glute and core weakness and poor hip control can lead to that valgus stress through the knee and contribute to anterior knee pain. And weak glutes also alters your shock absorption ability. So whenever your foot hits the ground or any closed kinetic chain situation, it'll increase the load around the knee joint. And one thing we don't like to talk too much about is rehabilitation errors, okay? But, every now and then, things can happen. Sometimes we can push too much too soon. Sometimes the patient pushes too much too soon. And therefore, aggressive rehab without that really good quality quads activation and really good quality patellar mobility can cause that anterior knee pain stress. Also, if you don't have really good control of the kneecap, the neuromuscular control before you start more dynamic procedures like your plyometric training and your jumping and your hopping, then that is really going to set you up if they don't have that control. Delayed quad strengthening, so on the other hand, if we're too late, it's a problem as well. So, and I think that's particularly interesting in the times where, you know, bracing might be happening. We've really got to be mindful that, you know what, quadriceps strengthening needs to be starting pre-HAB, okay, and especially post-HAB, but just really monitoring all your markers so that we don't get too much too soon, but we're also not delaying that path either. So common anterior knee-related conditions are patellar tendinopathy, your fat pad impingement, your patellofemoral pain syndrome, quadriceps atrophy, and your chondral defects and early OA. So I'm going to scoot ahead. I just note that anterior knee pain can happen at any stage of your rehabilitation. So of course it's really common to see it post-surgery, so in those early stages of post-surgical healing. And that can affect the patient in many ways. We also then see it when we're starting to push ahead with our muscle strengthening a little bit more, so anterior knee pain can happen for a variety of different reasons then. And then of course we can see it at the advanced stage when we're really getting them back on the field or on the court or into their daily life or onto the paddle court, which we see a lot of. You know, anterior knee pain can also start then, and that can be an indicator that maybe our quad strengthening hasn't been, you know, as optimal as we thought it had been going through that. So, assessment of anterior knee pain, we go through the regular assessment situations. Differential diagnosis and management. So if we talk about patellar tendinopathy, basically with the patella you've got, the pain is really localised at the inferior pole of the patella. You get pain with loading, okay? It gets stiff after inactivity because it's a tendon problem, and it's aggravated by a lot of eccentric loaded activities like you're jumping, you're squatting, and you're going downstairs. So it's really, you know, if you've got someone who has a problem with impact control and going down, then your patellar tendinopathy is probably one of the likely causes. It's also, you know, if you have a patellar tendon graft, then that's going to be highly likely there. When we're talking about pain management, we want some relative impact from rest. I often use some taping techniques to help to improve the circulation and also to change the mechanics of the patella. Lots of gait re-education, as Ashutosh was talking about before, and of course your isometric strengthening, progressing onto your slow eccentrics, making sure that you're working within a pain-free range. In terms of the biomechanical fixes, you really want to make sure that you can control the impact forces when a person is hitting the ground, because this is more of an impact aggravating condition, and you want to improve the foot biomechanics as well. Fat pad impingement is a little bit more medial and lateral to the patellar tendon, and it's pain with full extension, okay, or going into hyperextension. That's when you're thinking that the fat pad is the cause of the anterior knee pain. And all your extension activities. So what you want to do is you want to avoid them, or you want to sort of back off from them a little bit. Again, I'd be using a few taping techniques, lots of glute and core strengthening, and just really making sure that they can progress back into some softer landing mechanics. Okay, softer landing mechanics like what Dr. Anjana was talking about before in the kinetic chain. The knee is really affected by everything that goes along in the foot and the ankle, as well as the hip, I'm also going to say, as well as the spine and the shoulder as well. Patellofemoral pain syndrome is a little bit more of a diffuse pain around the patella. Again, it's a pain in flexion, but it's more that prolonged sitting flexion. So sitting in the movies for long periods of time, or maybe sitting down and watching your IPL match when nothing much exciting is happening. Okay, your treatment is you want to reduce those loads again, your glute, core and quad strengthening, and you definitely want to offload the quadriceps muscle and work on your hamstrings a little bit more. Quadriceps atrophy, you'll get your pain a little bit more superior to the patella, basically in the quadriceps. You want to make sure you've got your neuromuscular activation going on. I use a lot of MWM techniques for that, and progressive loading. And like they said before, you need to make sure that you get it back, if not to 90%, but definitely 100% of your, the same as the other side, basically. Patellachondral defects and early OA, you get some deep pain under the patella. The differentiating diagnosis from the patellofemoral pain syndrome, though, is you might get a little bit of clicking or locking, okay? That will just tell you that there's a little bit more of a chondral defect rather than just a general pain. So again, load modification, taping, a little bit of compression if there's a little bit of a fusion that has happened there as well, and some eccentric quads control. In summary, anterior knee pain is really common post-ACLR. Early intervention at any of the stage in rehab is critical, so if your patient starts to complain about it at any stage, make sure you assess it properly, know which structure you're treating, and work with that. Progression is essential, return to sort spacing, and psychological readiness are as important as strength, because anterior knee pain can cause those psychological disturbances, and prevent and educate in the long term. Thank you very much.